Sure. We're moving on to Francesca, who is a 51-year-old female with a history of celiac disease who's presenting for her annual visit. She was recently tested for hemochromatosis due to a positive family history in her brother and was found to have a PC282Y homozygosity. And I'm sorry if I said those numbers in a weird way, but that's what we're stuck with. Your labs are notable for a ferritin of 278, a TSAT of 59%, and an elevated hemoglobin of 15.1. And so I guess the follow-up question is, we're sort of in different territory now. So how is this case markedly different, and sort of what are the potential complications here as opposed? So let's just stop right there. What are the potential complications we might be on the lookout for?
Yeah, so this is a person who now is starting to fit the bill of someone where, if these were the only numbers that I got, I would be worried about genetic and partially at least penetrant hemochromatosis. She has a ferritin greater than 200. She's also coming at me as a woman with a history of a disease that is associated with iron deficiency. So I have a feeling that she has this ferritin has fought against great odds. So I'm a little bit nervous already. But the ferritin, although it can be diagnostic of hemochromatosis, it's typically the case that when it is less than 1,000, there's a higher likelihood that they have not developed cirrhosis. So back when we were trying to be very sparing with whom we would biopsy, we would actually wait until the ferritin was greater than 1,000 before deciding to biopsy to rule out cirrhosis. And it is true that if you present with hemochromatosis and a ferritin of 1,000, you're much more likely to have underlying cirrhosis. So my gut sense is that this is somebody who is about to get diagnosed with hemochromatosis, but we're going to have a much more laid-back discussion about it.
What would your spiel be like for this patient? How would you explain it, and what she might expect going forward if we were to find that?
Yeah, the first thing I would do is start drawing out the cascade from hepcidin to ferroportin in the jejunum. But I mean, at the end of the day, I think this person would be able to understand that their body is very hungry for iron, and that it's dumping it in the liver, and that when you start to dump extra toxins into the liver, it has the capacity to cause inflammation, which I liken to something like burning your skin. And if you burn your skin, it can cause damage. The redness or inflammation will eventually go away and can be left with a scar. And that same process can be occurring in the liver. And so the two main objectives that I have in clinic today are to talk about, one, how I can reduce the odds that she'll develop inflammation or scar formation, and two, be able to tell her, perhaps even today, how much scar tissue she has in her liver so that she can know about her overall liver health and the need to do other things like screening for liver cancer and so forth.
So what testing might you order as a follow-up to this? Because we have these baseline labs from Paul. Paul was referring her over to you because he had the same gestalt. So
that's exactly how this would go down. Yeah, so this feels great.
So, I mean, this is a good set of labs. I mean, if I was seeing somebody like this and I didn't know their liver enzymes, I would go get their liver enzymes. If I had their liver enzymes and they were elevated, I would ask about alcohol. I would consider checking a phosphatidylethanol or PEth level, which is a test that has really revolutionized my practice. I always tell people that I am going to be looking for a biomarker that tells me how much alcohol that they've been consuming over the last 3 weeks. I don't try to do this as a gotcha. And anyone who walks into my clinic who hasn't been checked for Hep C or Hep B is going to. But that's just to round things out. Beyond that diagnostic part, the prognostic information that I'll get, you can get in clinic by calculating something like the FIB4, which is based on the platelets, the AST, and the ALT. But in my clinic, I'll be using FibroScan, which has functionally replaced liver biopsy in this setting. So I don't need a liver biopsy to tell me if there's iron. In this person, I've got HFE gene mutations and a positive transferrin saturation and elevated ferritin. You don't even need an MRI. You know that they have a risk for hemochromatosis. And then I use my FibroScan to tell me about what the risk of cirrhosis is in this clinic today.
So you mentioned no MRI. Why wouldn't you want an MRI in this case, or what sort of case would you find the MRI helpful? Is it important to quantify like how much iron is in the liver? If you're testing, like if you do the FIB4 or you do the elastography and you're worried, okay, this person has advanced fibrosis, do you even need to do any further testing?
Yeah. So in this case, if we don't have any other competing diagnoses that could be manifesting in part as this dysmetabolic iron overload syndrome, then I would feel comfortable, and guidelines would allow me the privilege of providing this diagnosis face-to-face without any additional testing like MRI. But where the diagnosis is in question, or there are competing probabilities, and you need to know if there is iron in the liver to provide this person with the positive diagnosis of hemochromatosis, then you will go to that MRI. And once I know that they have advanced fibrosis or cirrhosis based on the FibroScan, and after my limited laboratory evaluation, I'm done. I can tell them everything that they need to know about how clinic with me is going to go on a semi-annual basis. People with hemochromatosis who present like this, who is otherwise asymptomatic, if they have cirrhosis, they're at increased risk of developing liver cancer. That risk will decline if we can remove the iron from their blood and get them down to a ferritin of like 50, but it will never go away.
That leads into sort of my next question about concretely sort of what does management look like from here? And obviously, the broader answer is it depends, but it sounds like it's mostly kind of, I'm not sure if this is the right term, like liver preservation, protection from viruses, minimization of sort of toxin exposure, that kind of thing. But when are you pulling the trigger on phlebotomy? And is there anything else that you're sort of in your armamentarium to, like, I guess, when are you making these decisions, and what guides sort of what happens next?
Yeah. So the key branch point is cirrhosis or no cirrhosis. Once you're in cirrhosis, you get that whole package where we start to think about liver cancer screening for varices. Like you said, general liver care, make sure that they're vaccinated against hepatitis A, hepatitis B, and then we'll talk about phlebotomy. But the sort of general practice that anybody has for someone with hemochromatosis is to tell them to, if they're taking a multivitamin, make sure there's no iron in it, to try to cut back on things like red meat. And then 3, because people with high transferrin saturations are at high risk of getting serious invasive infections from bacteria that require transferrin to get the iron for their own metabolism, like Vibrio vulnificus. We tell all people like this to avoid the coastal waters in the spring and summer, as well as to avoid eating uncooked or raw shellfish like oysters. So when it comes to phlebotomy, the goal is to get that ferritin to 50 to 100. That's our goal. And typically, I'll make a decision about how fast I want to get there based on how robust the patient is. So if they come to me with a ferritin of 1,000 and they're 36 years old, and we'll do phlebotomy once every week or 2 weeks until we get down to that low ferritin. If I'm a little bit worried about them, I'll space it out. And sometimes what I'll find when I'm doing phlebotomy is that the ferritin will plummet very quickly. And in that case, I've actually learned that the person probably didn't have penetrant hemochromatosis in the first place. I was probably phlebotomizing NASH. Which is something that a lot of people have done. So if you can normalize a very high ferritin very quickly, you're probably putting that person at risk of iron deficiency anemia, even with a high ferritin. And you can start to see that as the transferrin saturation will start to plummet, and the iron will be very low. So there's no hard and fast rule about how many units of blood need to come out before that person will normalize. But if you watch the kinetics for your given patient, you can get a better sense of what their total iron stores are and what the underlying biology that drove their presentation in the first place was.